Hi, this is Dr. Michelle O'Donoghue reporting from Medscape. I'm here at the ESC Congress in London, and one of the more hotly anticipated presentations is that of OCEANIC-AF. This is a trial of factor XI inhibition in patients with atrial fibrillation. So joining me to discuss the results is Dr. Manesh Patel. He is division chief at Duke. Thanks for joining me, Manesh.
Thanks for having me.
So let's start by talking about the theory behind factor XI inhibition.
Our hope always of the holy grail of trying to get to stopping clots and not bleeding, or what we've discussed is uncoupling thrombosis from hemostasis. And the history of our practice here in the coagulation cascade is for conditions like atrial fibrillation, we used warfarin, which affected many spots along the coagulation cascade. The good news is it certainly stopped clots, but there's a lot of bleeding. Significant advances, I'll call it, with direct thrombin or factor X inhibitors, like a doxaban, rivaroxaban, apixaban, that inhibited that and improved it. Factor XI inhibitors, and there are a few types, factor XI inhibitors that OCEANIC-AF used was something called asundexian, a small molecule affecting factor XIa inhibition. So activated factor XI. And what happens in the coagulation cascade is you have a common pathway, and then you have a contact pathway, which is thrombin amplification. So the idea being that if you inhibited factor XI, you might still have some normal hemostasis and clot formation that you need to stop bleeding, but you would stop the propagation of thrombus to get to that pathologic form. So that was the biologic concept. I often say it's our understanding of the current cartoon of thrombosis and hemostasis, but it's an important biologic process that was the hope.
Yeah, as you say, in many ways, this has been the holy grail because the DOACs were, of course, a big advance in the field of atrial fibrillation, anticoagulation management, and anticoagulation in general. But bleeding is still a significant concern. And, certainly GI bleeding has been one of those. The appeal of this class has been that idea that potentially you could have, your cake and eat it too, that you could prevent clot formation, without having the excess in bleeding.
Yeah, I think that's right. And I think that's the way almost all of our antithrombotic steps forward have been. If warfarin was leading to more bleeding, then the DOACs actually beat warfarin by leading to less stroke and atrial fibrillation, but a lot of it was hemorrhagic stroke and less bleeding. And so the concept for factor XIa inhibition with asundexian was first done in healthy volunteers, but then studied in some phase 2 studies to get ready for the atrial fibrillation study. And this phase 2 studies included something called PACIFIC-AF, where we aimed to understand how it looked in relation to apixaban against patients with atrial fibrillation. But because we have to do long-term studies, PACIFIC-AF was a short-term study looking at bleeding with 2 doses of asundexian, 20 and 50 milligrams, and looking at a factor XI activity assay to say, did you inhibit factor XI activity as you intended? And then was there a difference in bleeding compared to apixaban? And what was previously presented and published with PACIFIC-AF showed that at trough, about 92% of factor XI activity was inhibited with the 50 milligram dose, a little less with the 20 milligram dose. But overall bleeding was significantly less than apixaban. So the 50 milligram dose was tested and chosen to go into a large phase 3 study. These studies that we have to do to see if we can reduce stroke, systemic embolism, and the combination of that benefit for bleeding.
Well, I think you're highlighting the real challenge is about dose selection, ultimately, for a pathway that is not yet tested in terms of knowing its clinical efficacy. So as you said, you had the 11A activity data suggesting 92% inhibition of 11A at trough, as well as, 94% at peak?
Yeah. And it's pretty good thinking that we've got a reasonably high, it wasn't a huge amount of difference. And then the idea that there's significantly less bleeding. And not only is it dose selection important, we were trying to do it in a population that we would be testing against a comparator that we thought we would be using in phase 3. There are no perfect ways to pick doses. Obviously, that's the case. I often say I wish our bodies behaved like we learn in medical school with PK/PD, or we'd never have to do these trials. And so as we take them out into 74-year-old patients with atrial fibrillation and not normal kidney function, et cetera, that's sort of the action we were trying.
So let's talk about OCEANIC-AF.
Yeah, so OCEANIC-AF, unfortunately, was stopped early for inferiority, and I'll go through the trial design and talk about what we learned. It's a trial that was designed to evaluate asundexian, this 50 milligram molecule at that dose, small molecule for factor XIa inhibition, compared to apixaban in atrial fibrillation patients at risk for stroke or systemic embolism. And we define that as Chad's VAS score in men of 3 or greater, or women of 4 or greater. And if it was men 2 or 3, based on the guidelines at that time, you could have other sort of defined risk factors, age, renal dysfunction, prior GI bleed, antiplatelet use, or a naive, not having had an anticoagulant for 6 weeks. So that was the design. It was anticipated to be 1-to-1 randomization, double-blind study looking for the primary efficacy endpoint of stroke or systemic embolism and being not inferior to that at least. And then also looking to see if we have enough power, which we designed to see if we were superior for bleeding or net clinical benefit. The trial was designed to enroll 18,000 patients. And actually, we rapidly enrolled over 14,000 patients in 11 months from December of 22 to November of 22.
Which is remarkable.
Yeah, and it tells you that the desire amongst people to be on a better anticoagulant or a different one, or for the concerns that still exist in clinical practice around bleeding. Unfortunately, the DMC contacted us in November 19th of 2023 and said, we see a hazard with the asundexian increased rate of stroke or systemic embolism, and therefore the trial was stopped for being inferior for that.
So how great was the excess in stroke and systolic embolic events?
Yeah, a couple of important findings on that I want to make sure it's clear. You know, anytime a trial is stopped early, this was about a median exposure of 160 days. It's hard to know what the final effects would have been, so it can sometimes overemphasize or underemphasize findings. The cumulative incidence for asundexian stroke was 1.3% and 4% with apixaban. The hazard ratio is around 3.7 for more with asundexian compared to apixaban. And we presented the trial and actually described two key sets of data that we looked at to understand that. The first is we did have a planned PK/PD analysis. We're still doing lots of analysis in that. But it shows that at trough, both in OCEANIC-AF and in Pacific-AF, that level of 92% inhibition was still present. We don't have a lot of patients with events at 30 days that we had before because the trial was stopped early, but 10 patients that had a stroke or systemic embolism, the control group, those rates seem to be similar between those two groups. And then we did a subgroup analysis to say, are there subgroups that might explain this or things that we have? And the one group that we had pre-specified that had an interaction was patients who were previously treated or not. So those that were naive to oral anticoagulant, the curves look a lot closer together. The hazard ratio there is 1.45. This is pre-specified, exploratory, hypothesis generating, all those words we used to say, don't overinterpret this. What it likely tells us is there's some effect at this dose of factor 11 activity compared to apixaban, but not enough. And so those are the main conclusions, which is it's inferior to apixaban for stroke or systemic embolism. 83% of these patients were previously treated, well treated. The rates of stroke or systemic embolism are lower than we anticipate on apixaban, so that's something we have to work on. And I think it moves the field. I want to be clear. I think it moves the field forward.
And how so?
I think what we learned first is that this dose of this drug is inferior to apixaban, no question about that. And it likely may be that you need to have maybe near complete inhibition of factor 11 activity. And so that is a dose or pathway conversation, but likely a dose to say you might need more. The second is the population we studied, there's a price to pay if you don't enroll more naive patients or patients that are potentially not chronically on an anticoagulant and stable on that. And so it might be that there's a price to pay. Those are well-treated patients, have low event rates. You want to at least make sure you enroll some patients that are not chronically stable on the therapy. And lastly, this dose or others, whenever you change therapies, there's a risk, and you have to be careful about that.
Well, I think the dose question is an important one, right? Because I'm sure after your presentation, people will be grappling with the question, is this the end of the factor 11A story, or what can we really learn from this? And I think what I'm grappling with is, as you say, we see the 92, 94% suppression of 11A activity. And yet when I look at the excess in risk of ischemic stroke, I'm struck that it's almost as though it was behaving as a placebo. And I would have thought at first blush with that degree of inhibition, perhaps it's not quite enough, agreed. But I still would have thought that I would see, not the excess that was ultimately observed. Now, who knows, of course, had the trial been conducted to completion, if that would have been to some extent attenuated. But what are your thoughts there?
Well, I think the story it's just the beginning of the beginning in my mind. And I think there is activity. And the reason I'll tell you that excess is better than placebo is I think the question you're asking, is when we do look at those around 2,400 patients that were not previously treated with an anticoagulant, the curves are closer together. It's still not sufficient, but that has a ratio 1.45. At least makes me know that there's activity and therapeutic opportunity. The second is I want to be very clear. The new anticoagulants in atrial fibrillation rarely are significantly better at reducing ischemic stroke. They're better at reducing bleeding in the brain and the overall complexity of what happens to patients, not just with stroke, but staying on therapy and not stopping drug because of bleeding. And so I think the pathway for factor 11 is going to be a net clinical benefit pathway where when you get the right dose in this group and the right population, you get to a place where the hazard ratio is near 1 for stroke and the bleeding is so significant that patients stay on it and you get a benefit. I think that is a pathway possible. In this trial, all we can speak to is what we saw with this dose in this total population, and it's clearly inferior. Whether it's like what placebo would have done, we don't know because there wasn't an arm there. And we all speculate what we think the rate would be, but we wouldn't have speculated some of those rates even with the apixaban group. So I think there's a mixture of not just the rate we see, but how well the control groups also do.
No, and it's great to see that ultimately there are still ongoing trials in this space, and those will be ultimately, of course, the true test.
And they're well-run trials that I think will move the field forward.
Congratulations on a well-run trial, and I think it still informs importantly upon the space in general.
Yeah, thanks for having me.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.